Hello everyone. Today we will discuss rapid sequence intubation, aka RSI. It is one of the most critical life-saving procedures in emergency medicine, ICU care, trauma management, and pre-hospital settings. This session is designed not only for doctors but also for nurses, technicians, and paramedics because RSI is always a team procedure. Successful airway management depends on coordination, preparation, communication, and anticipation. We will cover when RSI is indicated, the patient assessment, drug selection, equipment preparation, and team roles, along with intubation technique, confirmation of the tube placement, difficult airway management, and post-intubation care. The main goal is patient safety, that is, securing the airway rapidly while minimizing hypoxia, aspiration, and hemodynamic collapse. So, what is RSI? RSI is a specialized airway management technique which involves rapid administration of an induction agent followed immediately by a neuromuscular blocking drug to facilitate endotracheal intubation. The purpose is to achieve fast airway control while minimizing aspiration risk, reduce hypoxia time during airway securing attempts, and increasing the chances of first pass intubation. The sequence is very important, that is, sedation or induction agent, followed by paralysis, that is, giving a neuromuscular blocking agent, and then go for intubation, followed by confirming the tube position and securing the tube. It is the gold standard for emergency airway management in critically ill patients or unstable patients. Remember, RSI is not just intubation, it is a protocolized team-based process. Preparation and practice determines success more than your laryngoscopy skills alone. Now let's quickly go through the indications of RSI. To remember, we will divide it in the mnemonic ABCDEF. A is for with patients having airway obstruction like burns in case of angioedema. B is for breathing, that is for severe respiratory failure, hypoxic or hypercapnic, if the patient is exhausted or the work of breathing is very high. C is for circulation, like in case patients with severe sepsis with shock, which may require airway control to reduce oxygen demand and facilitate resuscitation. D is for disability, means reduced consciousness, GCS less than 8 in seizures or traumatic brain injury. E is for the environmental factors like poisoning or severe agitation where airway protection becomes very necessary. F is for facilitation, that is to facilitate transport, imaging, procedures, or in cases of a combative patient who is pulling out his lines, you need to intubate the patient as so that the patient becomes safe. Additional indications are whenever you're going for a planned surgery, there is full stomach or high aspiration risk in cases of upper GI bleed, if you need to do an intubation, and like non-cooperative or combative patients, as we already mentioned. There are few contraindications of RSI. There are two absolute contraindications. First is complete airway obstruction. Second is loss of facial or oropharyngeal landmarks due to massive facial trauma, which requires surgical airway. Definitely don't go for RSI in those cases. There are certain relative contraindications as well, which requires caution and preparation, like in cases of predicted difficult airway or anticipated difficult airway, or in pediatric patients less than 5 years of age, or if your team is relatively new or inexperienced, then better not go for RSI, like I said, because RSI is a teamwork and you cannot do it all alone. You have to have your team as well should know what you are planning to do, and they should be well aware of the steps as well. So the real question is not how do I intubate this patient? Always keep the patient safe and always have a backup airway plan. Just like anywhere else, airway assessment is also as important in cases of RSI. So you have to perform a difficult airway assessment. For this, we will use the Lemon score. L stands for look externally, like facial trauma, if there is beard, obesity, or short neck. E, evaluate 3-3-2 rule, assess mouth opening and airway alignment. 3 fingers of interstitial distance, 3 fingers of chin to higher, 2 fingers thyroid notch to higher. M is for Malampatti scoring. We all know that. If you don't know, go through the images. O, if there is obstruction, stridor, swelling, tumors, blood, secretion, anything you are expecting. Neck mobility. N stands for neck mobility, important in mostly trauma and cervical spine diseases. Recognizing difficult airway actually allows you to prepare and have adjuncts. Like I said, always have a backup airway plan. Don't rush, prepare, and that will improve patient safety and keep your patient safe. Since in the beginning I said RSI is a protocolized approach, so the steps are also divided so that we don't miss. We divide into 7 steps, that is 7P. First is for preparation, second is for pre-oxygenation, third P is for pre-treatment or pre-medication, fourth P is paralysis with induction. Remember, induction first, then paralysis. Fifth P is for positioning and protection. Sixth P is placement of the tube with confirmation. And seventh P is for post-intubation management. So the first step is preparation. We will divide the equipment checklist into a mnemonic called SOAPME. S stands for suction. O is for oxygen. That is, if you require a NRBM or high flow nasal oxygenation or bag mask ventilation. A stands for airway equipment like endotracheal tube, stilet, bougie, video laryngoscope, surgical cricothyrotomy kit, whatever is required. P stands for positioning and pre-oxygenation. Patient has to be in the sniffing position, or if the patient is obese, then you have to put the patient in ram position, etc. That's for P. M is monitoring and medications. Make sure you have an SpO2, your UTCO2 probe is working, your monitor is all right, BP is in, and all drugs are drawn and labeled, whatever medications are required. And finally, E is your end-tidal capnography. End-tidal CO2, that is waveform capnography, is ready for confirmation of the tube placement. Once the equipment is ready, the next most important thing is the team. RSI is not a one-man show, so there has to be a team. Minimum 3 members are required. First is the airway operator who will do the laryngoscopy and intubation. Second is the airway assistant who will help the airway operator. And third is the drug administrator, which can be a nursing staff. Remember, before going for RSI, you pre-brief the team, assign roles, and you have to communicate within yourselves, and that communication has to be a closed loop communication like in ACLS. Now, once the equipment and team is ready, the first P, preparation, is gone. Next, moving on to the next P, that is pre-oxygenation. Pre-oxygenation is the process of giving a patient high concentration of oxygen before induction of anesthesia or endotracheal intubation to replace nitrogen in the lungs with oxygen. That is denitrogenation. The aim is to increase the body's oxygen reserve, particularly the functional residual capacity, aka FRC, so that during the period of apnea associated with intubation, SpO2 falls more slowly. So how do you do pre-oxygenation? In healthy patients, you give 100% oxygen through a tight-fitting, non-rebreathing bag mask at 15 liters per minute for 3 to 5 minutes, or you ask the patient to take 8 vital capacity breaths through that mask at 15 liters per minute. If the patient is desaturating, then you have to use a ambu bag with a PEEP valve and consider high flow nasal oxygenation at 60 liters per minute. And in certain cases, we also put in nasal prongs and give 15 liters per minute flow throughout the apneic period. That actually increase the safety window by 3 to 5 minutes. What is the target? Is to achieve an saturation of greater than 95% before induction. Ideally, it should be 100%, but more than 95 is acceptable. There is a term called delayed sequence intubation. If the patient is too agitated to pre-oxygenate, and I would rather want you to put that in comments if you know what is delayed sequence intubation. If you don't know, then I will make a separate video on it. Now, after pre-oxygenation, moving on to the next P, that is pre-treatment or pre-medication. This is an optional and should be individualized, like fentanyl. You can use fentanyl or lidocaine, or you can use glycopyrrolate, etc. for this dose. In certain cases, you also know defasciculating agents are given, which are rarely in used right now. So this P stands mainly for pre-medication or pre-treatment. Not going into details. Next comes the induction agents. The induction agent needs to be individualized based on your patient's physiology or pathology. I have enlisted the commonly used induction agents, and you can go through this and pick the induction agent which is ideal for your patient. Um, Mostly in patients of shock or hemodynamic instability, we have to go for either ketamine or etomidate because these are comparatively safer. If your patient is a COPD or bronchial asthma patient, you have to go for ketamine because it has a certain amount of bronchodilatory properties. Again, if your patient is um, having a raised intracranial pressure or raised intraocular pressure, if you're suspecting, then you better avoid ketamine. And just like that, you have this enlisted here, and each one of them have their advantages and disadvantages. So accordingly, individualize it based upon your patient. Once you have selected your induction agent, next comes the neuromuscular blocking agent. So there are two neuromuscular blocking agents that are recommended for RSI. One is succinylcholine and another one is the rocuronium. So succinylcholine has a very rapid onset, short duration of action, and you don't need to give any reversal agent. The patient gets reversed on its own after 5 to 6 minutes or 10 minutes maximum. The contraindications are hyperkalemia, severe crush injuries, neuromuscular diseases, burns of greater than 48 hours, and if there is a history or of malignant hyperthermia. On the other hand, rocuronium is longer acting. It is much safer in critically ill patients, and it is being increasingly preferred in modern day practice. It does not reverse on its own. It has a specific reversal agent called sugammadex. If you give sugammadex at the recommended dose of 16 milligram per kilogram, then you can reverse the patient from rocuronium immediately. Remember, once paralytic agent is given, the oxygenation becomes entirely dependent on the airway team. Uh, the SCCM 2003 guidelines suggest either succinylcholine or rocuronium may be used when no contraindication existed. And as we can already discuss, succinylcholine has a lot of contraindications, whereas rocuronium has very few contraindications. So rocuronium is every day becoming the more preferred agent worldwide. Next P of our positioning. Remember, proper positioning improves glottic visualization and first pass success. So first in positioning is first and most important is the sniffing position. Sniffing position actually aligns the oral, pharyngeal and laryngeal axes. In order to get sniffing position, you have to achieve flexion of the lower cervical spine and extension of the atlantoaxial joint. How do you do that? You do that by putting pillows or folded towels under patient's head, which raises the patient head by 8 to 10 centimeters. So sniffing position is mandatory and it helps for proper back mass ventilation and achieving a better glottic view. Next is the ramping position. Ramping position is done in cases of obese patients where you raise the upper body so that the external auditory meatus and the sternal notch are aligned in a horizontal straight line. Okay, then how do you do that? By putting pillows or towel rolls beneath the upper half of the body. We will see in the image later. Next is the cricoid pressure or Sellick's maneuver. It is done to reduce the aspiration risk. Okay, how it is done? It is done by applying pressure over the cricoid bone. The idea behind it is that since cricoid cartilage, not bone, cartilage is a complete ring. So when you put pressure over the cricoid cartilage, it completely obliterates the esophageal lumen and reduces chance of aspiration. How much pressure? When the patient is awake, you apply 10 Newton, and once the induction agent is given and the patient loses consciousness, you increase that pressure to 30 Newton. Nowadays, cricoid pressure or Sellick's maneuver has become obsolete or rather controversial because uh, there is no way, there is no device to measure that pressure of 10 Newton and 30 Newton. So it is become subjective, as a result of which it does not reduces the chances of aspiration as it was thought previously. More importantly, whenever if we are giving too much pressure during this Sellick's maneuver, that may impair the glottic view. So it is not a mandatory part of RSI nowadays. I would suggest if the patient is having high chances of aspiration or it's a full stomach patient, you can do Sellick's maneuver. But if you see that it is hampering the laryngoscopic view or glottic view, then you release it immediately. Next is the burp maneuver, that is the backward, upward, rightward manipulation of the glottis by a second person, that is the airway helper, which helps in improving the glottic view. It is done by putting a second, like I said, an airway assistant pushes the thyroid bone, grabs the thyroid bone and pushes in a backward, upward, and rightward way. Right means patient's right, and that actually aligns the glottis and provides a better view at times. So you this is also for one type of positioning that improves your glottic visualization and increases chances of first pass intubation. The SCCM guidelines suggest use of head and torso incline, that is semi-Fowler position, approximately 30 to 45 degrees during RSI, but that is a conditional recommendation and it has very low quality of evidence. Actually, raising that prevents the reduces the chances of aspiration, but if you are not used to it, you may find it difficult. So also it is not like recommended, it is just a suggestion. So you may go for it if you're comfortable, but if you are not, if you're more comfortable in supine position, you go for that. Remember, keep the suction ready. So if anything comes out, you have to immediately suck and get the airway clean. Now, this is just an image showing how you have to achieve a ramping position in a patient, obese patients. You have to raise the upper body so that the external auditory meters and the sternal notch are on the same line. And if you pre-oxygenate the patient, if you do a back mask of a obese patients, you have to make sure this that you put him in ramping position. Also, while laryngoscopy, it has been seen that putting patient in ramp position, ramping of the obese patients improves the laryngoscopic view or the glottic view. Now this image is showing the sniffing position. You can see once it is the patient is in sniffing position, the oral axis and the pharyngeal axis and the laryngeal axis are inclined in a straight line, and the both the bag mask ventilation and the laryngoscopic view improves a lot. Next comes the tube placement and confirmation. I am not going through the steps of tube placement. We all know how to place a tube. Once the tube have inserted the tube confirmation is done by continuous waveform capnography, and as it is considered the gold standard. Also, you can see for bilateral chest rise, bilateral breath sounds by auscultation, and absence of gastric sounds. Secondary confirmation is by a chest X-ray or an ultrasound. Um, Remember, never rely on chest rise or alone. Waveform capnography is a must. So while you are dealing with airway, you always need to have a backup plan. Same is in the case of RSI. You need to have a rescue strategy. So first is a video laryngoscope, or you can go for a bougie, or you can go for a supraglottic airway. Remember, if your first laryngoscopy fails, then optimize reposition, suction, burp, use those methods and immediately call for help, get seniors or experts there. And may God forbid, if you end up in a cannot intubate, cannot oxygenate situation, do not delay surgical cricothyrotomy. Do not go for another attempt. Go ahead with surgical cricothyrotomy. Remember, there should be maximum 3 intubation attempts before declaring a failed airway. And once you have declared a failed airway, then either you bring back the patient out of the neuromuscular blocking agent and abandon the procedure that day, or let's say you have to intubate that patient, it's a ICU patients, then you may have to do a um, surgical ecothyrotomy so that the airway is secure. Finally, coming on to the post-intubation care bundle, intubation is not the end, it is just the beginning of the critical care management. So once you have intubated the patient, you have to confirm the tube depth, you have to give the sedation and analgesia, you have to set the ventilator settings, you have to continuously monitor and do an ABG after 30 minutes, and you have to see if the hemodynamic parameters are all right or not, and you have to immediately activate the VAP care bundle. So I have in this slide, I have enlisted some of the high risk scenarios where you do RSI and what modifications in your plan may be required. Just like in case of a hemodynamic instable or in patients of septic shock, you have to reduce the doses of the induction agent by 30 to 50%. You go either for ketamine or etomidate, which are comparatively cause less hemodynamic perturbations, and always keep epinephrine ready. In cases of traumatic brain injuries, you better give fentanyl pre-treatment, and you had target a MAP of greater than 80 to maintain the cerebral perfusion pressure. In cases of status asthmaticus or COPD, you go for ketamine as an induction agent, but because ketamine has certain amount of bronchodilator um, activity. In cases of raised ICP, you have to avoid ketamine because ketamine increases ICP. It is debated, but better you go avoid ketamine, go for something other agents. And in cases of hyperkalemia, like we discussed previously, you have to avoid succinylcholine, go for opironium. And in cases of full stomach or high aspiration risk, you better avoid bag mask ventilation if possible. And finally, in cases of pregnancy, make sure pregnancy has a very high aspiration risk, and the patient desaturates very quickly. So you pre-oxygenate the patient properly, do a rammed position so that the intubation becomes easier because there are a lot of edema inside. So you make sure the position is also right. So these are certain high risk scenarios. You can go through them and use it in your day-to-day practice. Just like any other procedure, RSI is associated with complications which may occur during, before, or after intubation. Common complications include hypoxia, hypotension, aspiration, esophageal intubation, pneumothorax, dental or other soft tissue trauma. Most of these complications are preventable through proper planning and practice. This brings us to the end of our presentation. Thank you for staying with us. And if you like this presentation, then make sure to press the like button, share, and subscribe. And if you have any questions, you can ask in the comment section. Or if you have any topics in your mind that you want me to prepare presentations or give a lecture on, you can also post that in your comment section. Finally, let me summarize this presentation. RSI is a controlled protocolized emergency procedure. Preparation and teamwork are critical. Pre-oxygenation saves lives, so make sure you spend 3 to 5 minutes on pre-oxygenation. Drug selection should be individualized and should match your patient's physiology or pathology. Tube confirmation should always be done using waveform capnography. Make sure to have backup airway plans, and post-intubation care is equally important. Finally, if you may God forbid, if you end up in a cannot intubate, cannot oxygenate situation, do not delay surgical cricothyrotomy. And in the end, I would like to encourage you to develop protocolized RSI in your department along with checklist, because it significantly improves first pass success rates. That would be all for today. Thank you. See you in the next one.